Well, good afternoon. We hope you had a great lunch. We have designed this panel for after lunch to make some action item recommendations moving forward, and then having time for us to have some discussion around the call to action. So Dr. Lee Green is a professor and associate chair for information management in the Department of Family Medicine at the University of Michigan. He is going to moderate the panel. He's an active family physician with a full scope of practice. He directs the Great Lakes Research into Practice Network, otherwise known as the GRIN Network. And he has a robust portfolio of translation science, and we are pleased that he will be moderating this panel. He will be joined by Dr. Lou Bergio, who, if you'd like to just raise your hand. Oh, that you have a name tag, right? Great. Is the Harold Johnson Chair in Gerontology. He's also a professor of social work. He holds a joint appointment as research professor within the Institute of Gerontology and is adjunct professor in the School of Nursing and LS&A in the Department of Psychology. He's been a licensed practicing psychologist since 1983. From my perspective, Dr. Bergio is most, is actually pretty famous for his work on reach out for dementia caregiving in communities, and does a lot of work with dementia caregivers in terms of improving care. Scott Flanders is a professor of the Division of General Internal Medicine at the University of Michigan. He serves as the Associate Division Chief of General Medicine for Inpatient Programs, and is the Associate Director of Inpatient Programs for the Department of Internal Medicine. He directs the University of Michigan's Hospitalist program, and he is a founding member of the Board of Directors of the Society of Hospital Medicine, and he's a past president of that organization. He directs two hospitalist networks, which I think are important for you to know about, one in Michigan and one that is an international network, or a national network. Ann Sales is a professor in the School of Nursing at the University of Michigan, a research scientist in the VA Center for Clinical Management Research here in Ann Arbor. Her current areas of research include understanding mechanisms of reliable, effective methods of implementing evidence-based practice among interdisciplinary groups and general health services research. And last but certainly not least is Dean Smith, who many of us know as a professor, Department of Health Management and Policy, Director of Executive Education and Lifelong Learning at the School of Public Health. He's the chair of the M-Healthy Advisory Committee. He chairs the university's Pharmacy Benefit Oversight Committee and is a member of the Medical Benefits Advisory Committee. So he is strongly committed to a line of teaching and research and helps us in our MISHAR program to really understand the health economic components and interventions for implementation science. So please join me in welcoming this esteemed panel, which I think you will have a great time with this afternoon.
Thanks. We're going to go in the order listed in your program. I'm going to try to go through each person's presentation and comments in about 10 minutes per person, then open the floor for what we hope will be a very engaging discussion. Please think of questions, write them down, and put your thinking caps on as we're going along. Lou, you want to kick us off?
Good afternoon. Back from lunch, filled with energy, right? All right. So my task is to respond from my area of concentration, which is social and behavioral interventions. And specifically, my work has been primarily with elder dementia caregiving, specifically reducing the stress and burden of dementia caregivers. And the program that I worked with, the clinical trial was REACH, and the translation is called Reach Out. And there's a poster back there if you want to know more. So what I'm going to do is expand a bit on some of the themes discussed by Dr. Villeroy and Grimshaw, specifically some comments about clinical trials and treatment fidelity. And if I have time, which I rarely do, I do have a couple comments on Dr. Yates' fascinating presentation. So let's start kind of basic. Start with the term knowledge transfer. And for knowledge to be worthy of being transferred to the real world, it has to be evidence-based. And to be considered evidence-based, as it is now and probably will be for the foreseeable future, it has to come from an RCT, okay, and often more than one RCT. So let's think about the requirements of an RCT. Clinical trials are conducted under artificial conditions. The purpose of a clinical trial is to confirm, not to optimize. The focus is on internal, not external validity, so the focus has to be on controlling the variables. In our work on caregiver interventions, intended to ultimately be used out in the community and area agencies on aging and home health. These are some of what we did in the clinical trial. The interventions and assessments are completed by research staff, not case managers working in agencies. The interventionists and assessors frequently have more formal education and clinical training than community staff. A few more examples. Interventionists and assessors have access to PhD and physician level supervision. Researchers have often more funds, not so much these days, but often more funds available to dedicate to a program than a typical community agency. And feasibility is a factor when you do an RCT, but it is really secondary. What's primary is controlling your variables, all right, just like the real world. So after 11 years of NIH-funded RCTs developing the original REACH intervention, we ended up with an intervention developed under these artificial conditions that entailed the following: 12 in-home face-to-face sessions, okay, 12. The intervention had 8 treatment components. So it was rather complex. And I can give you a few other examples, but as you can see, not a heck of a lot like the community. But that's because the emphasis has to be on controlling your variables. Anyway, after all this time, we did get it published in a good journal, and it received a good amount of attention, and of course, most importantly, media attention, right? And if you get it in the New York Times or a place like that, that means you've really made it, and your intervention is worthwhile. And I'll tell you that there is truth to that, because NIH does track those kinds of things. Okay, so now let's take this evidence-based intervention and transfer this knowledge to the real world, right? And case managers or RNs if you're going to be in home health. So, obtaining the community's response required no research dollars at all. It didn't cost us a penny. No R01, not even an R03. We got a unanimous, reliable, and valid response. And it was something like, you have got to be kidding me. There's no way we're going to be able to do an intervention of this intensity. And it was rather loud. Oh, I can't tell my stories, can I? Okay. All right. I've got some good stories behind all these, but we're going to have to skip those. So anyway, obviously, and this is just repeating what's been said, but I think it's important. Implementation of social behavioral interventions frequently require significant adaptation or translation in order to be feasible in the real world. The problem is that there is no commonly accepted strategy for adapting an intervention from RCT into the community. this is the issue that really has obsessed me for, I think, about the last decade. There's a lot that's been written about it, fills a lot of journal pages, but if someone knows of a strategy that's agreed upon by all, let me know, because I haven't seen it yet. In our translation work, what we did was we formed a partnership with AAA case managers, AAA directors, and very importantly, the Commissioner on Aging. This was in the state of Alabama. In fact, she got the whole thing rolling. She called me about this project, so she was very much part of this team. Skipping a lot of details, what did we change and what do we keep constant? What we kept constant actually was the strategy, all right? That it was home-based, basically using problem solving. It was action-oriented. All the recommendations are written down to action plans. But what did we change? We went from 12 to 4 sessions. And as I frequently tell the story, I didn't sleep well for 2 years because I was trying to figure out how we're going to fit this all into 4 sessions. We deleted 2 treatment components, and that brought up the question from my colleagues. And that was, when does reach become not reach? To which I responded mysteriously, well, when does reach become reach? Because it is a logical fallacy that if you have, an 8-component, 12-session treatment package, that the outcomes say that you need to have 12 sessions. All you can say is that you did this treatment package, and these are the results. You don't know if there was 1 active component, if there were 8 active components. The only way to find out is by doing a component analysis design, which nobody does because they're extremely expensive. All right, so we don't know what the active components are. And am I out of time? You got a minute and a half. Oh, I can fit a lot in there. Okay. Right. All right. Okay. No, it's okay. Anyway, to make a long story very, very short, over the years, a series of small projects, and what we've developed is a highly vetted intervention manual where there's a couple components that sites can decide to bring in or take out, and that seems to be okay until we got to Puerto Rico. All right, so it's being done right now in Vermont, North Carolina, and Puerto Rico, and the reach out intervention needs to have a primary caregiver, right? A person that you take the data from, a person you impart the information to. When I got to Puerto Rico and I said primary caregiver, they said it'll never work. They won't accept it because they're very family oriented, and it'll start a fight if they have to decide who a primary caregiver is. So we had to tweak a little bit further, so it became more of a family intervention. So a little bit of a cultural modification there, and I am out of time. Okay. Oh well. Yeah, that's okay. Well, that's pretty much what I wanted to say anyway. But there should be a concluding sentence, and I can't think of one right now. So we're going to. Who's next?
Remember, this is a discussion. We'll be back. Go ahead.